Hello, everyone, and a warm welcome to today's edition of Pathcast. Today is Friday, October 6, 2023. I'm Rifat Mannan in California, and I'm remotely joined by my good friend Emilio Madrigal in Boston. Today, we are very delighted to welcome back Dr. Andres Matoso, who needs no introduction to the audience. So he is an associate professor of pathology at Johns Hopkins University, and he is a very renowned genitourinary pathologist. So today he is going to give a talk on renal tumor classification of WHO updates, and the title of his talk is Updates on the Classification of Renal Tumors, WHO 2022 and Beyond. And many of you are aware that he is the author of this very popular book. So this is the Survival Guide to Prostate Pathology. And those of you who have not read it yet, this is a must-read book, and please find out from the website of Innovative Pathology Press so that you can get a copy of it. And as always, please feel free to post your questions and comments on YouTube and Facebook chat windows, and we will pass them to Dr. Matoso at the end of the session. And thank you, Dr. Matoso, for joining us today. Over to you now.
Thank you, Rifat. It's my pleasure to be here today and doing a lecture. And I went to the Pathcast website, and it seems that it has been over 2 years, so it was about time. So glad to be back. So today we're going to talk about a topic of renal tumors and the most recent classification of WHO and what has happened since. This is probably the area of GU pathology that has seen the most developments in recent years. And it's overwhelming for people who don't practice this specialty every day. So I'm going to try to go over some of the most recent advances. This is not going to be a review of all the kidney tumors, but instead of it's going to be a review of what has been learned during the last 3 to 5 years.
So Dr. Matoso, do you mind turning off your video?
Yes, I forgot about that.
Sorry.
The problem is I don't know how to do it.
It might be on the lower left.
Yeah, sorry about this.
Oh, it's okay.
Oh, here, maybe I'll talk here. Stop video. Okay,
yeah, thank
there
you.
you go. All right. So these are the ones that were called emergent entities in this classification from 2022. So we had a thyroid-like follicular carcinoma. It's not present in this classification, but it's mentioned in this table. And the only advancement in this is that this translocation or this fusion has been discovered molecularly and published in different publications. So it has been validated by different groups. Then we have, sorry, I don't know, we can go back. Yeah, we have the eosinophilic vacuolated tumor, or which used to be called a high-grade oncocytic tumor. It was a little bit of a misnomer, but we're going to talk about that. Then the lot or low-grade oncocytic tumors, the biphasic hyalinizing cymomatous renal cell carcinoma that was described first by Pete Argani and our group, and then a little bit about papillary neoplasm with reverse polarity. That is a subtype of papillary renal cell carcinoma, even though it's called carcinoma here. These are very low-grade tumors that have the characteristic of having KRAS mutation. They have reversed nuclear polarity. They're very pink, well circumscribed, and so far we don't know of any cases of metastasis. So instead of calling it carcinoma, we're calling it neoplasm. In the WHO, it was left within the chapter of papillary renal cell carcinoma, so that's a little bit confusing, but we're still learning. So in the note, when we have that diagnosis, I make a comment that so far we don't know metastasis, but we're still learning about this entity. So it's not yet so well established whether it should be called neoplasm or carcinoma. We call it neoplasm because we have not seen any metastasis. So I'm going to cover aspects of these tumors that I have divided into oncocytic tumors, tumors with clear cell, Wilms tumor with B-RAF mutation that is this entity is absent in the WHO, tumors with papillary features we have about that biphasic hyalinizing and cymomatous renal cell carcinoma, and then some others that have been published as new progress in this area, and also includes the carcinoma with a fusion. Some of the sentences might be in Spanish, given that these lectures are adjusted in English to Spanish and Spanish in English all the time, and I sometimes get behind in the translation, but it'd be helpful for people from Spanish-speaking countries that are not few. For example, in this, where we're talking about a low-grade oncocytic tumor, that I still had not changed the title. But this is from the publication from Kirill Tripkov that was the first to describe this entity. And these are what we used to consider at some point eosinophilic variants of chromophores because they're diffuse positive for CK7. But they have the characteristic of being negative for CD117. As you can see by morphology, these tumors are composed of nests of tumor cells that have very bland looking nuclei, sometimes with a little salt and pepper chromatin or very tiny nucleoli. Occasionally, you can see a little bit of clearing around the nuclei. But in contrast to oncocytoma, these are very packed together nest of tumor cells, and you would not see that sort of loose myxoid edematous areas that you see in oncocytoma. Additionally, these are diffuse positive for CK7, which would be completely inconsistent with oncocytoma. And as I mentioned, they're negative for CD117. You would expect that chromophore RCC to be positive for CD117. These tumors, and this have not been published yet, are also positive for a new marker that we will discuss later during this presentation. It's called GPNMB. Just bear in mind this marker. This marker is overexpressed in tumor cells that have tuberous sclerosis 1, 2, or mTOR pathway alterations. So positivity can be helpful in identifying tumors that are related to these mutations that can be both sporadic or hereditary. Here we have an example of a needle biopsy of a kidney tumor. We can see that edema in between the tumor cells is not present. These tumor cells are still organized in small nests. They have very bland looking nuclei. And this is a perfect candidate for a low-grade oncocytic tumor. It does not completely fit into oncocytoma, especially if we do immunohistochemistry for CK7, we'll find out that it's diffusely positive. You can see here the nuclear feature a little bit better, where there is not a nuclear irregularity or wrinkling or things that you see more in chromophore RCC. Here's another example of a kidney mass that had been biopsied. And here you see also the arrangement of tumor cells into nests. But you can see that the nuclei are still very round, very smooth nuclear membrane. In contrast to the previous cases of low-grade oncocytic tumor, this is also an oncocytic tumor. Tumor cells are arranged in nests, but you can see here that the cell membrane is much more prominent. This should be a hint that this might not be a low-grade oncocytic tumor. And instead, it will be one that is included in the differential diagnosis that could be, for example, eosinophilic variant of chromophore renal cell carcinoma. The distinction is important because one is considered benign, the other one is considered a carcinoma. And in this case, if we do the immunohistochemistry, we see the diffuse positive staining for cytokeratin 7 as well as CD117. If it was a lot, it would be CD117 negative. And another kidney biopsy where the tumor is eosinophilic, but in contrast to the previous cases, the tumor cells in this case are not arranged in a small nest. And the eosinophilia of the cytoplasm is quite abundant. They have very abundant cytoplasm, and you can see a little bit of stippling in the cytoplasm with some basophilic inclusions. So here the differential diagnosis now includes eosinophilic solid and cystic renal cell carcinoma. And you can see here a little bit closer where that cytoplasm can have granularity or inclusions. And you can see that the architecture in this area is solid. So it fits into the solid component of an eosinophilic solid and cystic renal cell carcinoma. These are more common in women because they also could be associated with TSC1, 2, or mTOR pathway alterations. They can be part of a syndrome or be sporadic. These are also positive for cathepsin K, where we see here the tissue has not stayed very well in the slide, but you can see there is the strong diffuse positive for cathepsin K that can be helpful. And in contrast to the other cases, this is positive for cytokeratin 20 that can be diffuse or focal, as in this case, and they're negative for cytokeratin 7. All right, so we had talked about low-grade oncocytic tumor, a distinct entity now. There is benign, and we talked about the main differential diagnosis and how we can work them up in resections or in needle biopsies with a few immunohistochemistry stains. We introduced a little bit that GPNMB as a marker of TSC1, 2, and mTOR pathway alterations. So now we're going to go into what is called a high-grade oncocytic tumor at the beginning that now turned into eosinophilic vacuolated tumor. And you see this initially was called carcinoma as well, but is now also known that these have a very favorable prognosis, and therefore was changed to eosinophilic vacuolated tumor. In contrast to low-grade oncocytic tumors, these tumors have cells with abundant eosinophilic cytoplasm and vacuoles, as the name indicates. You can also see the arrangement in nest. There is a little bit more of myxoid or edematous stroma in between the tumor nests. The nuclei are going to look very high-grade with very prominent and large nucleoli. But these cases, and as you can see here, they use the very prominent nucleoli in the vacuolated cytoplasm. But the name of high grade was dropped because these cases do not have metastasis. So they also behave in a benign fashion. They can have chicken wire calcifications as seen here. And it's also demonstrated to be part of the TSC1, 2, and mTOR pathway alteration in publication from Victor Reuter and groups and other groups as well. It's important to consider that these cases have to be tested for PAX8 because one of the main differential diagnoses would be an epithelioid angiomyolipoma that is fat poor. Now, angiomyolipoma would be negative for PAX8. These tumors are also focally positive for cytokeratin 20, similar to eosinophilic soy and cystic, and also cathepsin K positive. The cathepsin K positive is also a marker of AML, so it needs to be worked up with a PAX8 as well. SDHB, because of the resemblance with SDHB deficient tumors, was well documented to be retained just for completion of the workup. You can see that CD117 is negative. In this case, CK7 only highlights entrapped tubules. So here are some of the molecular alterations and immunohistochemistry profile, and other publications from other groups have confirmed similar findings, similar morphology, immunophenotype, and with good prognosis of these cases, even though it looks higher grade. A very recently introduced entity is xanthomatous giant cell renal cell carcinoma, also from Peter Argani and our group. And we have two cases of such tumors, and similar to eosinophilic soy and cystic RCC, these have tumor cells with very large amount of eosinophilic cytoplasm. And in addition to the cytoplasmic inclusions, these cytoplasm have very foamy xanthoma-like appearance, but they are cytokeratin positive. And also similar to ESC, these tumors are positive for cathepsin K and cytokeratin 20. And you guessed it, because they're associated with TSC1, 2, and mTOR pathway, they're also positive for GPNMB. As you can see by the low-grade morphology here, these have a fibrous capsule. They're more sheets of tumor cells and not arranged in nest. So the architecture is already suggestive of a higher grade tumor, has an infiltrating pattern, and these patients already presented with metastasis at the time of diagnosis. Here you see the evidence that these tumors are also associated with the TSC1, 2, and mTOR pathway alteration, with our new marker GPNMB being positive. So we have LOTS, we have ESC, we have AML, and we have xanthomatous giant cell renal cell carcinoma as examples of GPNMB positive tumors. They're also positive in translocation RCC that we are not going to talk about today, but just bear in mind that you have to use this marker in correlation with the morphology. These are the two cases of xanthomatous giant cell renal cell carcinoma, a proposed new entity that show the alteration in the TSC2 gene. Now, carcinomas with alteration in the ALK gene, this has been expanded significantly recently. Initially, it was thought to be almost exclusively of children and children with sickle cell anemia, and also eosinophilic tumors with a lot of vacuoles, very high-grade looking in morphology, but in general, good prognosis in children. And there were a subset of different translocations that were known, and that has been expanded. And now we know that they can happen in adults, in tumors that have a lot of dysplasia, that are poorly differentiated, and that can have a worse prognosis. And more studies on molecular analysis of different tumors have led us to know now that there are a wider range of alterations in tumors that have various morphology. For example, in metanephric adenomas that have some atypical features with mitosis or even vascular invasion, or in tumors that look similar to mucinous tubular and spindle cell carcinoma, where it has areas of higher grade and also concomitant alteration with ALK. There are other tumors that can have papillary structures and are positive for ALK. Here it demonstrates some TTF1 positivity in these cases, but these, if you look at the paper, these were with the clone that is less specific for TTF1, the SP28G, and not with the one more commonly used, that it doesn't lead to these positivity in different tumors, but it was not tested in these cases that were presented here. But the point is that some papillary RCCs that are difficult to classify, or they're not traditional for papillary, they also could express some ALK. Some of the RCCs that can have this vacuolated and intracytoplasmic mucin could be ALK positive as well, with similar morphology as you would see in lung adenocarcinomas. Here's an example of a metanephric adenoma that otherwise, if it wasn't because of ALK, this has positivity for all other markers of metanephric adenoma, and it's unclear whether this should be called a carcinoma. There is vascular invasion, it's mitosis, because otherwise morphologically it's a metanephric adenoma, and we're still learning to see whether this translocation with ALK it has any significance in these cases. You can see here the metanephric adenoma with ALK alteration. Some omatous calcifications, and all the traditional morphology with little tubules, with cuboidal type of cells, and no mitotic activity in general. All right, so we moved on with the all oncocytic tumors. Now I'm going to talk a little bit about tumors with clear cell. And in this field, you're going to refer to renal cell carcinomas with fibromyalgia trauma. I'm going to talk about this marker again, GPNMB, that has been shown to be as overexpressed when there is an alteration in TSC1, 2, and mTOR pathway, and also with translocation RCCs. So this is a summary of the main tumors where we're going to see a lot of GPNMB. For example, in clear cell RCC with fibromyalgia trauma and TSC1, 2, and mTOR pathway alteration. A recent publication that came out from our group a couple months ago shows that in this, with tumors with this morphology, broadly separate into two categories, either ALK or TCEB1 mutation, or TSC1, 2, or mTOR pathway alterations. The ones that have TSC1, 2, and that we tested, that we had confirmation of molecular alterations, had shown to be positive, strongly and diffuse for GPNMB, similar to eosinophilic and cystic RCC and to translocations RCC, as you can see in this figure. This is a figure from similar tumors that were molecularly found to have TCEB1 or ALK alterations. or TSC1 and mTOR pathway alterations. So most commonly, these tumors are strongly and diffusely positive both for cytokeratin 7 and CA9. So this is represented here in C and D in both cases. But you can see morphologically the tumor cells are have abundant clear cytoplasm. They have papillary structures, and they're separated in large nests by this stroma that have fibromyomatous differentiation. They're almost indistinguishable or indistinguishable by morphology. So when you have this morphology, you can think about two different molecular alterations behind it. But GPNMB is only positive in the ones that have TSC1, 2, and mTOR pathway alteration. It's important to mention that the GPNMB, in order to be considered positive, has to be strong and diffuse in the tumor. There's many cases where it's going to be patchy or very focal or weak positivity, which was not the case of the 6 cases that we have of ALK or TCB1 mutant RCCs. But you can have focal immunostaining, for example, in papillary renal cell tumors or in clear cell RCCs, but it's not going to be associated with TSC1, 2, or mTOR pathway alteration unless it's strongly and diffusely positive. Here, I'm going to share a consult case that I had not so long ago, where you see this partial nephrectomy with a mass that appears to have 2 components, one here at the periphery and another one more solid at the center. So when we look at the periphery, it had that characteristic architecture in large nest composed of tumor cells that line papillary structures, and these tumor cells have abundant clear cytoplasm. The stroma that separates the nest has this fibromyomatous differentiation that can be highlighted with desmin, with SMA, or other smooth muscle markers. In the center of it, there was an epithelioid component that which the cells have abundant eosinophilic cytoplasm, and we can take a closer look. That eosinophilia is sort of wimpy in areas with not so strong, and the nuclei look very bland. The no mitosis in the center. So when we do immunohistochemistry, again, this emphasizes that they're positive for CK7 and CA9. The CA9 is stronger in the papillary epithelial component and a little weak in the epithelioid component. And PAX8 is positive in the epithelial component with the papillary structures, while negative in the solid epithelioid component that was towards the center of the lesion. But when we do GPNMB, it's strongly positive in both components. The epithelial component at the center was very strong, and then also strongly diffuse positive in the areas that are papillary, and they have those cells with abundant clear cytoplasm. So this is an example of a tumor that occurred in a young lady that had both an epithelial AML and a clear cell RCC with fibromyomatous stroma. And this indicates an alteration in TSC1, 2, and therefore that patient should be worked up potentially, given that she had a young age for tuberous sclerosis syndrome, or at least we have to suggest that there could be such alteration. Okay. Now we're gonna move on to Wilms tumor with B-RAF alteration. So the Wilms tumors and metanephric adenomas were thought to belong to a single category a long time ago, and there was a lot of discussion whether metanephric adenomas could be the mature form of Wilms tumors. Until we identified that metanephric adenomas had mutations in B-RAF, and Wilms tumors didn't. And therefore, there was a hypothesis that these were unrelated. Occasionally, we had seen some nephrogenic rest at the periphery of Wilms tumors that were considered part of remnants, but not true components of the tumor. So now I'm going to present a clinical case that led to this other publication about B-RAF alterations in Wilms tumors. And this was a kid that was 6 years old. As you can see, a little bit off for the age of Wilms, but not terrible late. And you can see that Wilms tumors can happen in adults too, although very, very, very infrequently. And this had a tumor that when you look at low power, you can see it had solid areas here towards the left of my screen. and then another solid area here, and then in between a lot of cystic areas. So when we look at the solid area here on the left, you can see that the epithelial component had these elongated cells, and then there were a nest of tumor cells with very primitive appearance and a lot of mitotic activity. As you can see here closely, this looks at very primitive look to it with some epithelial structures and maybe some blastema in between. And when we look at the area that is cystic, we can see also that the lining has these columnar epithelium, more similar to the Wilms component that was seen before. And then the metanephric adenoma component that is part of the tumor too, you can see that in contrast to the other area here, the cells have no mitotic activity. They have nuclei that are round, they're cuboidal, they're making little tubules, characteristic of metanephric adenoma. So the patient was diagnosed with Wilms tumor. He had a radical nephrectomy, was followed by chemotherapy for Wilms. And a year later, develops a single metastasis in the lung, and therefore he goes into a lung resection. And this is that specimen you can see here, the inked margin and the pleura. And this tumor that had morphology similar to the previous Wilms tumor in areas, but other areas looked also a little bit more cuboidal, suggestive of similarity with the metanephric adenoma component. Now, the patient was treated with radiation and followed with chemotherapy, but a few months later, after completion of chemotherapy, additional nodules presented. So therefore, the clinicians requested that this metastasis in the lung, the one already resected, to be sent for next generation sequencing. And in the sequencing, the B-RAF B600E mutation appeared. Then we proved that with immunohistochemistry, and it shows here now with red chromogen that these tumor cells were positive for B-RAF B600E, which is the most common of the B-RAF mutation. Here you have a closer look with that red chromogen and tumor cells being diffusely positive for the mutant form of B-RAF. Then we pulled the original kidney tumor from 2 years prior, and the tumor, the original kidney tumor, both in the area that had the Wilms morphology and the area that had the metanephric adenoma morphology, both of them had diffuse staining for B-RAF B600E. Here you can see the cystic area with the red staining in tumor cells. So this led to identifying other cases that had similar mixed morphology of Wilms tumor and metanephric adenoma. And they can happen in children or in adults. This patient responded very well to B-RAF inhibition and was all the lung metastasis melted at 1 year after the identification of this molecular alteration. So other cases that we also identified were in adults. So the message is that when you have a Wilms tumor that is predominantly epithelioid and that has areas that show metanephric adenoma morphology, it will be wise to do B-RAF B600E immunohistochemistry to identify a subset of these Wilms tumors that will not respond to traditional Wilms chemotherapy, but instead to B-RAF inhibition. Now we're going to talk about biphasic hyalinizing psammomatous carcinoma. This is called biphasic because it has two cell populations. Some of them have abundant cytoplasm, and some of them have very scant amount of cytoplasm, and that's what gives it the name of biphasic. It has papillary structures that mimic little glomeruloid structures, as you see here. There is a collagen 4, or this is the hyalinization component of the name, is these little globules of collagen that you can see in the tumor. And these have mutation for neurofibromatosis 2 gene. So these patients can be, in the initial series, they were all sporadic despite this NF2 mutation. Now, it's important to note that 50% of unclassified RCCs will show NF2 mutation. That doesn't mean that it's the driver mutation in the tumor. So you have to have both components, the mutation and this morphology, for the tumor to be classified as a BHP or biphasic hyalinizing pseudomonas calcification. These are images not from the publication, but from another case that I had after the publication. We started identifying them by this peculiar arrangement of the tumor cells into nest, the deposition of collagen in between the tumor cells and the pseudomonas calcifications. And remember this image because when you have an area like that looks like this, you can then identify by immunohistochemistry by the product of NF2, which is Merlin, in the study that Andy Acosta very elegantly carried on and showed that it can be used in the diagnosis of this new entity. And here you can see the tumor showing the pattern that I just showed you in the previous image. Now, initially we thought these were going to be all sporadic, but then sure enough, a consult came to Dr. Argani for this 10-year-old, not zero as it came out here, 10-year-old girl who had already signs of neurofibromatosis with bilateral schwannomas and confirmed NF2 mutation in tissue and in normal tissue. And you can see the morphology again here with these papillary structures mimicking glomerular structures, some more solid nested areas with the pseudomonas calcification that I had mentioned. Identify this as a nice pattern to recognize this entity and the collagen globule. So it has the morphology, it has the genetic alteration. Patient was doing fine at last follow-up about 10 months after the resection of the kidney mass. Other tumors that have been, we have learned a little bit more recently are tubulocystic carcinomas that initially were supposed to be tumors that were small, 2 to 3 centimeters, located in the pole of a kidney in a patient that would be 70 to 80 years old, unencapsulated, but with high nuclear grade features. But we would not give it a nuclear grade. That, by the way, we only give nuclear grade to clear cell, papillary, or unclassified in certain situations. But this will have very prominent nucleoli and hobnail appearance of the tumor cells and very spongy like of architecture. But there is a subset of these tumors that have solid areas or even sarcomatoid transformation that caught the attention of very astute researchers. And they have identified that these tumors have very prominent nucleoli, papillary structures, and they have deficiency for fumaric hydratase, as you can see in this image where the tubules of the tumor are negative. You always have to have some internal control with vessels where you're going to see this granular cytoplasmic staining. And this next to it is 2SC, or which is the precursor molecule present prior to FH, which will accumulate if FH is non-functional. It's important to combine these two. In cases of FH retention in immunohistochemistry, then you do 2SC. If the clinical suspicion and the morphology is highly suggestive of FH deficiency, if the tumor is positive for FH, it can still have a deficiency. They have an FH that is non-functional. And in that situation, we accumulate 2SC. So that's why it's helpful to have a second antibody for these cases. Unlike SDH, where there is always loss of staining, when there is a mutation, FH can still have some protein identified by immunohistochemistry, but be non-functional. Then we're gonna, I'm gonna present this isolated case report from Dr. Marino and her group at the NIH. And this is a very interesting case report of a patient who had multifocal kidney masses and also had an appearance of this biphasic look to it. And some of the cells with scant cytoplasm could have also pseudomonas calcification. And remember, ADH is another Krebs cycle enzyme. So it had a lot of similarity with other tumors. I have not come across any cases like this yet, but it's interesting to pay attention to any further development into this area and upcoming publications. We keep an eye on this, but it's interesting that it was multifocal, had IDH2 mutation, and had this biphasic with some of its calcifications as well. And these are the two other publications that I picked up with this follicular thyroid-like carcinoma that can happen in the kidney, and that we have to do thyroglobulin or other thyroid-specific stains if we want to separate kidney primary from a metastasis from thyroid carcinoma, because they're both going to be PAX8 positive. And they were found to have this fusion with the Ewing and PAX1 and gene. So there's going to be probably more to learn about this as well. So I think I'm just going to summarize now that we had the oncocytic tumors, also the sentomatous giant cell RCC, the oncocytic that is low grade, or the vacuolated cytoplasm, or the eosinophilic and vacuolated tumor. And they all have in common that they are associated with TSC1, 2, or mTOR pathway alteration. Remember to do PAX8 to distinguish them from epithelioid AML. And then we're going to learn more about GPNMB in this setting as well. They usually have a very good prognosis, so it's important to make the correct diagnosis in these entities. Remember that Wilms tumors that present in an age that is unusual, older than 5 years old, that are epithelial and they have undifferentiated areas, can have areas with metanephric adenomas. They need to be sampled well so we can identify those areas and do the B-RAF immunohistochemistry. Also, carcinomas that are difficult to classify, that might look like MTSC or metanephric adenomas, or papillary renal cell carcinomas, or very eosinophilic. They can have ALK alterations, and they could also be detected by immunohistochemistry. So ALK is a good marker to remember when we are unable to classify a tumor. We presented also a biphasic hyalinizing psammomatous carcinoma associated with NF2 mutation, and that can be identified with loss of expression of merlin, which is the protein product of NF2. We talked about tubulocystic carcinoma with solid and high-grade areas that have to be tested for FH deficiency by immunohistochemistry and the combination with 2SC. I introduced a little bit this interesting case of multifocal RCC with IDH2 mutation as well. And then we looked at the very pretty cases of follicular-like renal cell carcinoma, follicular thyroid carcinoma, like renal cell carcinoma, that we now know that they have a fusion with Ewing's and PAX1. And with this, I'm just gonna thank you in Spanish, and I'd be happy to take some questions. I was told now to turn on the camera, so let me see if I can do that successfully. And thank you so much for your attention.
Thank you so much, Dr. Matoso. So this was amazing for your comprehensive review of so many different new entities in the WHO classification. There are quite a few questions online, and there are some comments as well. And one general question, so maybe I will read it for you. It seems that the WHO classification is changing often. Is it because of new molecular alterations, or is it because of new histologic markers that are making them more distinct in their morphologic patterns, or there is any, or the prognostic significance that we are able to know more? So maybe you want to address it.
I think we had some broad categories that have been expanded now, or subgrouped into smaller types of tumor, in part due to access to immunohistochemistry and molecular studies. 10 years or 20 years ago, molecular studies were very rare in tumors. Now there are more available to researchers, and they're also performed more commonly for patient care purposes. And therefore, we are going retrospectively from a certain clinical outcome that requires NGS studies, and then those findings that are correlated with the morphology, and then we look for additional cases. For example, that's the situation with biphasic hyalinizing psammomatous calcification, psammomatous carcinoma, or the B-RAF positive Wilms. And so I think that has been driving most of the changes is the access to new information, molecular information that we didn't have before.
Right, thank you. There is another question about one of your patients. This is what happened to the patient after doing chemotherapy for Wilms tumor with B-RAF mutation? Was the patient treated? So that was the question.
Yeah, so the patient was treated with B-RAF specific inhibitor, and the lung mets melted. I think that turned into a case report later. And but that was at 1 year time. Remember, the B-RAF therapy, usually, at least for melanoma, that is where we know the most, it has a very successful 1 year or a year and a half of response, but then the tumors usually have a way to bypass that inhibition. But at least from this patient evolved positively after changing from chemo to B-RAF specific therapy. So these can have therapeutic implications, and that's why I mentioned them in the presentation. I know these are very rare, but if we don't know about them, we're never going to detect them.
Right. Thank you, Dr. Matoso. So there is another question about ELOC carcinoma. Is it positive focally for cytokeratin 7, or
Yes.
it must be diffusely positive?
No. Initially, all the low grades are more likely to be cytokeratin 7 positive, and that was the case. Now, similarly to what I mentioned earlier, with the performing NGS, in more cases, we have seen higher grade tumors. The NGS was requested because it gave metastasis, and then we go back and we see that they have ALK-TCEB. And in my short series published recently, I had 2 cases that were negative for CK7. So not always the strong diffuse positive for 7 and CA9.
Right. Thank you again. The next question is, what are the most useful histologic differences between oncocytoma and LOT, as now some pathologists prefer diagnosis of LOT in tumors with overlapping features as to be on the safe side?
They're both safe diagnoses because they're both benign. The most critical would be to not underdiagnose the chromophobe RCC. So in the case I showed, the morphologic differences that I emphasize is the stroma in between the tumor nest. The LOTs, or low-grade oncocytic tumors, don't have that loose edematous myxoid stroma that is characteristic of oncocytomas. They're both usually don't have a capsule, but occasionally you can see a fibrous capsule in some of the low-grade oncocytic tumors. So they're very, very similar. The main difference is in immunohistochemistry. LOTs are diffuse positive for cytokeratin 7. The advantage of knowing this entity is that before knowing this, we would have called diffuse positive CK7 low-grade oncocytic tumors, we would have called them eosinophilic variant of chromophobe RCC. Now we know that if it has this morphology that we discussed, is diffuse positive for CK7, don't have a very prominent cell membrane, and they are negative for CD117, then we're safe to call it LOT, especially if we do GPNMB. Chromophobes are patchy for GPNMB and not strongly fused, as we can see in LOT, but this is an observation that is not published yet. I'm just giving you before it comes out.
Right. The next question is about GPNMB. Actually, the question is that would you recommend GPNMB as a part of ISC panel for the newer RCCs in
Absolutely.
WHO?
We have, especially with all these new entities that are associated with TSC 1, 2, and mTOR, they have positivity for GPNMB. And there are some inhibition that is specific to these pathway alterations. And these patients have syndromics, they can have multiple kidney tumors, so it's important to identify in the biopsy as such. They might be subject in the future to some targeted therapy, and avoid to be chopping off pieces of kidney in a patient that will eventually end up in dialysis if they have a syndrome that leads to multiple kidney tumors. So more to come on this marker, but we have incorporated it 2 years ago, and it's one of the most commonly used right now in our practice.
Thank you. So the next question is, in cases with carcinoma with leiomyomatous stroma, can we find also multifocal tumors like we can detect in angiomyolipoma and not be considered metastasis, especially both have some same molecular changes?
Absolutely. And what I have not seen yet are cases that have many of them, but you can see tiny baby AMLs in the background. I showed a case where both are large tumors and there were sort of like a collision, AML and RCC with fibromyalgia stroma. But yes, those patients, if they were to have a syndrome, they'll be younger and they have likelihood to be multiple. They also have a very good prognosis, but they're considered carcinomas. They can metastasize.
Right. There are quite a few comments, Dr. Matoso, about the WHO classification per se, which is more generic. I would read one for you that, do you think that in the near future, there will be morphologic diagnosis and molecular integrated diagnosis separately because too many specific molecular markers were launched and it needs time and it's time to catch up, or it needs time to catch up? Do you have a comment on it?
Yeah, I cannot predict exactly how this is gonna evolve. I can say that I've been waiting for this to evolve a little bit more to write a book about kidney tumors, so it wouldn't be outdated at the time of publication. So I don't know if there's going to be two separate diagnoses. I think they have to be put into context. And there are certain molecular alterations that are frequent, for example, NF2, and that's what I emphasized. Without the right morphology, it wouldn't be a biphasic hyalinizing psammomatous carcinoma, but instead it could be just an unclassified RCC that frequently have NF2 mutation. So as we go and we learn more about these alterations and immunohistochemistry pattern, I think there's going to be significant changes in the upcoming WHO. As an example, I mentioned several entities or findings that are already not present in the last year's WHO that will be present eventually in upcoming editions. So to answer the question, I don't know exactly where we're going to go. I would guess that it's going to be a combination of morphology, molecular, and immunohistochemistry. And that's probably what's going to, and clinical correlation. You know, we don't, a lot of these categories, we don't really know yet what the clinical significance is. But we put it out there. It's important that some of the new entities have helped us distinguish what is benign from malignant. So that's progress.
Right. No, I think because we have, that's a great point that you brought up about the clinical significance of Matoso. We have a lot of viewers who are from different countries that, so they might have issues about, availability of immunostains or molecular markers to categorize these new entities. So do you have any suggestion for our colleagues?
Well, I think you need to have, there are certain markers. Someone asked me last week when I was in Uruguay in a lecture, so we cannot diagnose any renal cell tumors anymore if we don't have available immunohistochemistry. And there are certain cases that we can diagnose. We can diagnose oncocytoma. If it's very classic, we still able to diagnose a clear cell, conventional clear cell RCC. We can diagnose papillary RCC, and those are very common tumors. So we can still diagnose 70% of kidney tumors without immunohistochemistry. Now, once you have immunohistochemistry available and the tumor is not classic, then you're obliged to use it because you want to give the right classification. But I don't think it is that critical in all the cases. As long as you can distinguish what's carcinoma from benign, and you can give a broad idea of what are the features present to be able to prognosticate and to choose available therapies. I think a good communication with the clinicians to see what would make a difference in that particular clinical setting and practice. There are a lot of targeted therapies that are not available. Now, if the patient is some patient with different resources, that is not the average for that particular place, and has access to more sophisticated medicine, then send it for an international consult would be the appropriate course of action. So I think the important thing is communication with the patient and the clinicians to set up expectations of what should be in the pathology report and not waste resources where resources are scant. And it shouldn't be a stressful situation. It should be honest, a simple description of what you have without guessing too much, and also following what's more frequent and what's super rare. And with that in mind, I think we can still work even in the absence of immunohistochemistry or molecular.
That's a great advice, Dr. Matoso. Thank you so much, because this question we keep hearing from our colleagues as there are new entities, not only in GU, in other specialties as well. Just for example, it's very difficult nowadays to probably diagnose oligodendroglioma in a place where molecular techniques are probably not available. Then, as you said, probably like, there has to be a middle path where we are honest and try our best to report with whatever resources that are available. But there has to be changes, there has to be advances as we are, having newer amenities and newer information. So, and science has to progress.
I agree.
Thank you so much, Dr. Matoso, for this excellent talk on this WHO update on renal tumors. And let me tell you, you would be very happy to hear that we had a lot of viewers who joined from so many different countries across the world. And I could keep track of our colleagues who joined from countries as far as Burma, Mexico, India, Zimbabwe, Kosovo, Pakistan, Serbia, Egypt, and someone joined from Uruguay to Italy, Ukraine, Ireland, and many people joined from US as well. And thanks to our viewers for your support, and thanks for following Pathcast. If you like our lectures, so don't forget to subscribe to our YouTube channel or our Facebook page. And we also have a website where the lectures can be found. And our next lecture is coming up on, again, WHO update on head and neck tumors. That is on October 17th, and it will be a two-part lecture by Dr. Lester Thompson. He's a very renowned head and neck pathologist, and hope to see you at that time. That's on October 17th at 12 p.m. Eastern Time. Thank you so much. And thank you again, Dr. Matoso, for this excellent talk.
Thank you, Rifat, and thank you everyone for connecting, and look forward to the next opportunity to be here again.
Sure, thank you.
Bye.
Bye.